In part 2, I'm going to discuss the clinical model. And I'm trying to show how the clinical model is deficient in that it completely disregards an important aspect of the consequences of war, and that is moral injury. Over the past 40 years or so, veterans have been subjected to a progression of diverse clinical psychiatric procedures for treating PTSD. Cognitive therapy, pharmacological therapy, and cognitive behavioral therapy, and some really weird stuff like eye movement desensitization and reprocessing. Yet, vets continue to suffer depression, anxiety, guilt, alienation, and a host of other problems. And they still exhibit high rates of suicide, of alcoholism, drug addiction, homelessness, and violent crime. Tragically, as soldiers experience the horror and the cruelty of war, and especially of urban counterinsurgency war, the moral gravity of their actions become apparent. That is, the displacing of civilians, the torturing, injuring, and killing of other human beings. They may suffer the consequences of acting in violation of their moral identities, the moral foundations by which we structure our lives. That is, soldiers not only suffer the effects of trauma, but also of moral injuries. That is, debilitating guilt, remorse, shame, loss of self-esteem and of self-respect, disorientation, and alienation from the remainder of the moral community. Consequently, to subsume all invisible wounds under the PTSD umbrella as mental illness is misguided and fails to address the totality of the injuries veterans have suffered in war. Now, whether we act rightly or wrongly, that is, whether we act in accordance with or in violation of our moral identity, will affect whether we perceive ourselves as true to our personal convictions and to others who share our values and ideals. Moral injuries, then, are, in most cases, an inevitable consequence of the sophisticated manipulation and distortion of a recruit's moral foundations experienced during basic training, made worse by the profound moral confusion and distress they experience as the horror and the insanity, that is, the reality of war becomes apparent, and they are confronted by the realization of the moral gravity of their actions in combat. Moral guilt, then, is, simply speaking, a combination of the awareness of having transgressed moral convictions and the anxiety precipitated by a perceived breakdown of their ethical cohesion, that is, their integrity, and an alienation from the moral community. Shame is the loss of self-esteem consequent to a failure to live up to personal and communal expectations. Now, the observation that some human beings become moral casualties because of their experience in war is not new. Historically, many societies have recognized war's deleterious effects and have required returning warriors to undergo elaborate atonement and purification rituals. For example, quarantine, penances, etc. Now, these therapies provided a means and the ample opportunity to cope with the moral enormity of their actions in war. Tragically, however, the moral injuries of modern warriors have been virtually ignored, overlooked, or disregarded by the conventional psychiatric community, operating as it does within a Freudian scientific legacy that views ethical concerns as clinically irrelevant. Focusing instead on stress and trauma, most moral symptoms presented by returning soldiers are either not taken seriously or are assimilated under the diagnostic umbrella of post-traumatic stress disorder. Consequently, the veterans received a signal that an inability to forget, to put the war behind them, is either weakness or, perhaps worse, mental illness. Accordingly, veterans are advised to ignore what has occurred, to de-responsibilize or neutralize their feelings by accepting the naturalness, the normalness of their behavior on the battlefield, and or to undergo a myriad of conventional therapies intended to enable them to deal with the stress and trauma of their experiences. In either approach, moral considerations are, for the most part, irrelevant. Unfortunately, in most cases, moral injuries don't respond well to medication or traditional clinical therapies, nor can they be rationalized away. Such therapeutic advice as forget it, or live with it, or act as though it never happened, or don't worry, it's quite normal for human beings to act in that way in a survival situation, does little to alleviate the veteran's moral pain and suffering. As may be expected, the prevalence of moral injuries suffered by those who fight in morally ambiguous wars or in counterinsurgency guerrilla war, such as in Vietnam, in Iraq, Afghanistan, where, for example, the distinction between combatant and non-combatant is obscure at best, will be significantly greater and the symptoms more severe. However, all wars yield moral casualties. Even the actions and the experiences of those involved in a good war, such as World War II, and who did not directly confront the enemy on the battlefield, can precipitate moral injury. Consequently, contrary to some military apologists, it is not the case that debilitating remorse, guilt, shame, and so on may be avoided by educating, or rather by convincing soldiers about the justness and necessity of war and the appropriateness of their combat behavior. Now, to correctly identify and adequately treat combat-related PEM injuries suffered by our servicemen and women in war, we must appreciate the relevance of moral values and norms to defining ourselves as persons, structuring our world, and rendering comprehension of our relationship to it and to other human beings. We must understand that these values and norms provide the parameters of our being, what I term our moral identity. Most importantly, we must recognize that combat behavior often violates our moral identity and negatively impacts upon our self-esteem, self-image, and integrity, thereby causing debilitating remorse, guilt, shame, disorientation, and alienation from the remainder of the moral community. This is moral injury. Now, acknowledging the existence of moral casualties in war demonstrates, I think, that the clinical model, pathologizing a veteran's readjustment difficulties as mental illness, is inadequate and requires further evaluation. On the positive side, it enhances our understanding of the war experience and its devastating effects. It expands our area of concern beyond trauma and PTSD and allows us to more adequately meet the needs of our returning servicemen and women.